So 5, 4, 3, 2, and 1. All right, folks, welcome back to the Trauma Therapist podcast. I am very excited to have as my guest today, Veronique Mead. Veronique, welcome.
So great to be here, Guy.
All right. So Veronique was an assistant professor of family medicine and obstetrics at the New Hampshire-Dartmouth Family Practice Residency program for changing careers. She retrained as a somatic trauma therapist, and for the past 20 years has been integrating existing research on trauma into a new model for making sense of chronic illness. The model emphasizes the need for trauma-informed approaches in medical care and beyond. Veronique's work draws from her personal journey of gradual recovery from disabling chronic fatigue syndrome, asthma, and other symptoms. She shares the science of how trauma influences physiology on her blog, Chronic Illness Trauma Studies. Veronique, welcome.
Thank you. Great to be here.
Thank you so much. So before we get going here, share with our listeners where you're from originally and where you are currently.
I was born in Chicago, raised in Canada, and I've been in the Boulder, Colorado area for the past 20 years.
Okay. So what a shift. I mean, it is a huge shift from focusing, or how long were you a practicing physician?
I started my medical training in 1990, and then I left around 1998. So part of that was training. Part of that was being faculty and teaching.
Okay.
Yeah.
Okay. So I guess however way you want to slice and dice it, it appears like it's a huge shift.
Big shift.
So let's walk through it. What compelled you to make that shift?
It took some time. I had thought the medical thing was really where I wanted to go. And I started to feel as though I didn't have the right tools to be really working with people. And it's more clear in retrospect, but there was something that felt off. I really liked connecting with patients, but there wasn't a lot of time. Mm-hmm. And there was also this sense of this term that's coming out. I think you've done an interview with this around moral injury, this sense that I was actually, because of something that I really didn't have familiarity with, and I didn't know what it was, that I was maybe causing harm. And I felt this most in obstetrics. Women coming in, I followed them through their labor. I often would inherit sort of someone in labor when I was on call who had been induced for whatever reason, rather than going into labor naturally. And those were difficult. They often ended in complications or a C-section. And it just felt off, and I didn't quite know what it was. And so there were a whole series of things, and I just felt really inside, I was starting to feel worse and worse with this practice. And so the decision to leave was a big one, and I took some time.
If I may, for 1 second. So yeah. It wasn't that you felt, well, maybe I'm in the wrong specialization, or I need other training within, the field. It wasn't that.
It wasn't that.
Okay.
As a child, I had an image. It was as if the image had happened. It hadn't. But the image was of an ambulance parked down the street from where I was growing up. And in that image, there was somebody laying on the street who'd been hurt. And there were people from the ambulance who were there to help. And I had this image through a lot of my childhood and throughout my training. And when I left medicine, I took a year off because I thought, maybe if I do something that's mostly outpatient and I'm not working as much on call because I had no life, maybe that would help. But when I ended up after taking a year off, I woke up one morning and thought, I wonder if there's a psychology program that would be interesting, that would work. And I ended up finding this program in somatic psychology. So this was an orientation from one of my role models, Rachel Naomi Remen, a pediatrician who changed careers. And there was a component of believing that there was an intelligence to symptoms. And so I found this program at Naropa, and in writing my application, the image came back with the ambulance. And I had always thought or felt this sense of wanting to help people. And when I was writing this paper, it was a whole different orientation, and it was more of wanting to accompany and be with. And what I've learned with everything I've learned about trauma was, if I can just be with that person while other people are doing what they need to know, so they know they're not alone, so they know that it's okay. There was something about that that ended up being a part of that shift.
What a profound shift. I mean, and such a, I mean, you can feel it, you know, when you talk about being with, that's heavy stuff. That's,
Yeah.
and to what degree is, I don't want to say antithetical to being a physician, but is it unaligned with being a physician? It's not as what emphasized.
I wonder if that is what is at the core of being a physician or in any health profession. But with how it's all evolved with insurance and not enough time and who's running what we can do.
Right.
I so appreciated the connection I had with my patients. That was really the highlight. And then becoming a therapist and being able to sort of midwife the process and providing the education and the information and letting them know it's not their fault. Now, how do we look at this together? Was that was a really profound experience.
So you move through, take the initial steps into this transition. You applied in Naropa, and give us kind of the thumbnail of what Naropa is for the listeners who aren't familiar with Naropa.
Naropa has a Buddhist-based philosophy and approach, and the way I saw it, what I took from it was really this concept of mindfulness, being in the present moment, non-judgment, curiosity. And they have a variety of different psychology programs, undergraduate and graduate. And so the Somatic is one of the graduate programs that they have. And it ended up really aligning with my sense that there is an intelligence in the body, that symptoms may be intelligent and actually provide us with clues if we can learn how to listen and follow that. And so that's really what the training was. You do a ton of training of listening to your own system and learning where it wants to go and what it wants to do. And so while I was there, I ended up having a couple ahas that sort of began to link things together for me.
Okay. Well, let's share some of those ahas with us. Those are always interesting.
Yeah, so there were two major ones. The first was writing a paper for one of my classes in the first year. This was an introduction to somatic psychology, I think. And I was looking for an example while I was writing this paper. And the philosophy that I learned in somatic psychology is a sense that what leads to symptoms, let's say PTSD, is an interruption from a normal activation deactivation cycle. So an interruption to a fight flight response where we're unable to overcome, unable to adapt, can't escape it, can't flee. So that's a position, let's say, that a child might be in an abusive family household. And that when that cycle cannot complete or do what it needs to do to get you to safety, or to get your nervous system to perceive that you're safe and it's over with and it's done, when it would then deactivate and come back to a parasympathetic rest digest mode. So if we get interrupted in there, that's the trauma, the definition of trauma. And that's where we can end up having symptoms, sort of getting stuck in that activated cycle. So I was writing the paper and I was thinking about PTSD, and I was wondering, is there any way you could think about this with chronic illness at a physiological level? And all of a sudden it was, what if chronic physical symptoms are a similar interruption in an activation deactivation cycle? What if blood pressure which normally will rise a little bit as part of mobilizing, whether that's going for a jog or a walk. What if that got stuck from an interruption? And that was my big aha question of, could trauma be a risk factor for chronic illness and physiological changes? So that was the first big aha sort of question. And I started diving into the research. Is there any evidence that trauma is a risk factor? And I started to find some. And it led to the second aha, where I went to a conference, an APA conference. That's the Association for Pre and Perinatal Psychology and Health, and met Tony Madrid. And Tony Madrid's a psychologist in California, and he's been working with kids with asthma for the past 30 years. I met him 20 years ago, so he'd been doing this for a while already. And his story was the second major thing that happened for me. He accidentally discovered that by identifying a mother's experiences of adverse events in the pre and perinatal period, so when she was pregnant with her child that had asthma, maybe the case story he published about it was a 9-year-old girl who'd been going to their clinic where they'd been doing all kinds of therapy, family therapy, visualization, guided imagery, and nothing had helped with Chrissy's asthma. And so the mom decided, when they decided to stop that, the mom decided to keep doing therapy. And one day she told Tony, you know, I feel terrible saying this, but I don't feel love for my daughter. I know I'm supposed to. I wish I did, but I don't.
How old was his daughter again?
9 years old at the time. Yeah. And so a big light bulb went off for Tony. He had just read a book his wife had given him, written by 2 pediatricians who discovered the role of disruptions in bonding and events that separate a mom and baby, either emotionally or physically. So incubator care separates mom and baby. Stress for mom and dad, or if parents separate, that's an emotional stressor. So he then asked Chrissy's mom what had happened when she got pregnant, during the pregnancy, the birth, and he found all these events that were interruptive to bonding. So he did either hypnosis or EMDR with her, and it resolved those. He then sort of helped her imagine the ideal birth, what would have been like for that pregnancy and the birth and those events. And Chrissy's asthma went away.
Wow.
Yeah. It treat the mom and it treats something in the child. I have goosebumps even now talking about it 20 years later. It's the most sort of exciting, inspiring evidence or example I've seen. And so that was the second big aha, was, okay, can trauma be a risk factor? And then, wow, healing trauma can actually heal a chronic illness. Never heard of that before. And so I kept diving into the research, and I got really curious. How could that possibly be? How could we possibly explain that? And so the research has been, I've been kind of finding bits and pieces that I think might help put this together.
Wow. So, okay. So you in turn, started working with people or treating people or helping people? Did you went through school and you became a therapist?
Yes. So okay. I wrote my thesis, my master's thesis. I looked at the research in type 1 diabetes. That's an autoimmune disease. And it's the one so far that I've seen the most research done on the role of adversity, even though they still don't really talk about it much. It hasn't reached the clinical world yet. Okay. But so I wrote that, did my thesis with a case study where I interviewed an adult with type 1 diabetes and looked to see what might be in his past. Does that fit? And then I practiced psychotherapy for maybe 5 or 6 years. And my specialty and my interest was chronic illness. So I worked with folks with IBS, but also IBD, which is the inflammatory bowel disease, more the autoimmune version, lupus, type 1 diabetes, chronic fatigue a lot. I think they came mostly because, in a way, and this is the chronic illness I've had for 20 years, it's still thought by most to be a psychosomatic disease. So it's sort of thought not to be quite as real as an autoimmune disease, say, where you can actually identify biological markers to prove and to diagnose that it's real and that something's going on. And people improved. It's a much slower process than I ever thought. People did not go into a total cure, but it started making a big difference. They started having less flares, being less sensitive to triggers, started catching what the triggers were so that they could do something, whether to prevent it or when it happened to not freak out as much or to help it not take as long.
So are you talking about a relationship or correlation between trauma and chronic illness?
Yeah.
But correct me if I'm wrong. Isn't it common knowledge that trauma does affect people's or can cause physical ailments? Or is that not true?
I think it really depends what tribe you're in and what group you're talking to. Physical ailments like chronic pain, there's more, I think, more understanding about a link there, but that's still not common. And it's certainly not common in the medical community. And I think even among those of us doing psychotherapy, we may think about psychotherapy as a way to help someone manage their chronic illness, but we don't tend to think about it as a way to help them shift the physiology, shift the nervous system perceptions of threat that may be driving the symptoms. That is not a common perspective. It's fairly common in the somatic psychology world. So somatic experiencing, SE, sensory motor psychotherapy. But the further you get away from the somatic psychotherapies, it seems to me the less there is of a concept about it being a risk factor.
Right. Interesting. It just seems kind of a no-brainer to me. It does. I'm like, wait a minute. Maybe it's because we're doing this all the time, but it just seems, of course. What do you mean?
Of course.
Almost so crazy. Of course it's going to impact and affect. Yeah. And man, so, okay. So what are you doing with this? What is your goal, I want to say?
Well, it's been a very interesting journey. Our journeys are so not linear things we expect them to be. My own chronic illness got worse over about a 10-year period from the time it started when I was practicing medicine. It continued even though I took the year off. I thought if I really de-stressed, that would help a ton. And instead I got worse.
Jeez.
I know, it's really surprising because our perception about the role of stress, that's the big thing. And this is really common in chronic illnesses, that there are typically a series of stressors or traumas, or maybe one event, or maybe it's an infection that's the last straw trigger before onset. And it's a different thing for everybody. And it can be different things for the same chronic illness. So infection, trauma, surgery, divorce can be a trigger for someone with all kinds of people with type 1 diabetes or other autoimmune diseases, or for chronic fatigue. So that de-stressing thing is what we often try to do, is to address the thing that triggered the chronic illness. And it typically doesn't cure the chronic illness, trying to heal the infection that triggered it, for example. So the de-stressing didn't work for me. I went to Naropa after that, and I very slowly got worse. And it was sort of like, I didn't even really think I was that sick, but there were a lot of things I couldn't do anymore. I couldn't go for long hikes. If I went too long, I'd have a big flare up, and then my new baseline would be worse. And so When I learned about trauma and the chronic illness connection, it still took me a few years before it was like, oh, maybe I've had trauma that I can work with. And I could not for the life of me think of anything I'd experienced that was really traumatic. Also very common for those of us with chronic illness, unless it's been a very overt, like abuse. And I have no abuse in my history at all. So I started doing trauma therapy, working with this, coming sort of back into my body. Didn't even realize I wasn't fully in my body. I was pretty disconnected and didn't realize it. Big intellectual kind of, that's a survival piece for me. And it was sort of the image I have for that is like a huge cargo ship. And it takes a while when it decides it's time to stop. It takes a while where it keeps going before it can actually come to a full stop and then turn around and start going the other direction. And so that probably took me about 10 years. And during that process, I ended up having to stop practicing psychotherapy because my fatigue had gotten so severe. I would work with someone, say, with a heart arrhythmia and other symptoms that they had that may be a freeze state, a dorsal vagal, polyvagal theory state where their whole system is kind of in a bit of a shutdown. And I would just want to lay on the floor. My own symptom and system would just be so resonating in a way with that. So I stopped doing psychotherapy, got worse for a little while, and then having that time off, I got a great disability insurance coverage, which made a humongous difference, was from back when I was a doctor. And that allowed me to then start adding other things, acupuncture, Ayurveda, herbs. And I started to climb out of it, but that took 10 years also. And I'm not fully out of it yet. Very common. I mean, some people will recover quickly by doing, let's say, a major dietary change. But I did that for 4.5 years and that helped, but it didn't help me fully recover. And so what's my goal, you ask? You know, what I've done in the past, it's already been 10 years since I stopped doing psychotherapy. And although I'm doing much better, I'm at a place now where my curiosity and interest has been, what's the research? What's the evidence? How do I share this and who do I share it with? And it took me a few years to have enough energy and capacity to start a blog. And that's where I was able to share these perspectives for people with chronic illness. So they don't have to wait until doctors start to change their own awareness of it, which could be a while.
Right, right. Let me just remind everyone that I'm speaking with Veronique Mead. Your blog is Chronic Illness Trauma Studies. That's chronicillnesstraumastudies.com. And when I realized when I said, what's your goal? That's just something sounds so, I don't know, antiseptic about that. I didn't mean that. I was blaming my ability to find the right word there. As you're sharing this story, there's something to me feels almost demoralizing. You're going through doing all these things, trying to get better, and what's working? How do you deal with that?
That's a really good question, because from this big picture that does have a goal in it, and it feels more like an intuitive goal that I don't really know exactly where I'm going. I'm just following where the passion is. It has been very difficult. There have been very demoralizing times, but the big picture feels to me like I really need to understand, is the trauma piece really a connection? Is it really something that we can work with? If you do, can it really make any difference with chronic illness? Because it's met with so much skepticism, but it's also because we're in a culture that for 100 years has really thought about trauma as being purely psychological, that it's purely means that something is broken or that someone is broken, and that it's all in our heads. That's the medical model and the mind-body split between physical illnesses and psychological illnesses so established at this point that to mention the possibility of trauma as a risk factor for not just psychological illnesses, but also physical, it's often when people with a chronic illness hear this, many of them are really angry because they think I'm saying it's in their heads, because that's what their doctors and the whole system and their families have been telling them for a long time. So it's a really kind of a tricky topic in our current culture that is still really quite unaware of the science behind trauma. Right. So there's a process about how long it's taking me to dig myself out of the hole. It's kind of like the size of the Grand Canyon. That's what it feels like. But I keep getting ahas and insights and awarenesses, and I keep seeing how trauma has played a role, but very subtle, very, very subtle, so subtle that even after doing this for 20 years, looking at the research, working with people, hearing their stories, I am still regularly surprised if I have a little bit of a flare up, or if I have a trigger, or if I have a symptom. It's like, that came out of the blue. And then when you work with that and you're with that, and you realize, oh, there was a trigger. It still surprises me. So it feels to me that the length of time it's taking me to come out of this may be helpful for others for whom it's taking a long time to climb out. And we don't really know at this point, how far can we come out? Can we really cure chronic illnesses? Can we prevent them by knowing this? And so in the big picture, I'm actually really appreciative of the depth of information I'm gaining from this journey, this incredibly frustrating journey at times.
I feel, and maybe I'm being naive here, but I feel that there are a lot of other people out there who would be listening to this and going, yes, of course, this is what, I'm experiencing too. When you said, when people hear that trauma piece, they maybe tend to feel it's just in my head, and it's not just in my head. There's that saddens me to hear that, but as you said, I mean, that's the cultural perspective, the lens, in a sense, the major lens that we're dealing with right now.
Yeah, it is. And I think there's a wave happening with the adverse childhood experiences, the ACE studies being at the forefront of changing the perspective on a global scale.
Right.
And it's still seems to be more in the psychological, social world. So in schools, it is happening, reform in prisons. California's first Surgeon General, Nadine Burke-Harris, is a pediatrician who is at the forefront of ACEs. And
I was thinking about her. Have you talked to her?
No, I haven't spoken with her, but I've read her book. It's one of my favorite books for getting a good sense if you haven't read about or heard about ACEs. And they're just starting to do universal screenings. I think that's going to take a lot of awareness and growing with that information to become trauma informed and not just see it as a scale. There's a lot of concern that it'll be used in a way that we've done before for judgment, or for an insurance company to put someone in a hole. But there are some pediatricians, especially in California, who are implementing this in their practices, and it's changed how they work, and it's changed how they work with parents who may have their own traumas that are influencing how they parent. But they're turning out that parents are appreciative, and they're gaining resources so they can be better parents. Yeah, so there's some good things afoot.
Yeah, that's awesome. This seems like a study in semantics about how you present this potentially.
Yes.
Be very, very, one might want to be very cautious and thoughtful. Not that you're not doing that. I'm just saying, thinking about myself here. Wow. Incredible work. So, all right. So as we kind of wind down here, if people want to contact you, Veronique, how could they do that?
Best way is through my blog, chronicillnesstraumastudies.com. They can find my email there. I actually love hearing from people, how things are working for them, because there are people who have and are using this perspective, and it's so helpful in their lives. So,
Awesome.
yeah.
Awesome.
Yeah.
All right. How about a go-to book recommendation? You mentioned Nadine Burke-Harris's book. We'll link that up. But and even aside from trauma or chronic illness related, what would you offer?
Ooh, aside.
Anything that's inspiring you.
Yeah, I am starting to read less about trauma, but I want to mention some trauma books because it's hard to find books that present the trauma perspective with chronic illness. And one less well-known book by Stefan Hausner, who does family constellation, multi-generational work, is called Even If It Costs Me My Life. It's more expensive, but it is filled with case examples of work with people with all kinds of different chronic illnesses, people he's worked with over the past few decades. And I really like Peter Levine's books. Waking the Tiger was the first book I ever read of his. I still find it among my favorites because of his easy writing style. But he also wrote In an Unspoken Voice, and he writes about being hit by a car and how he used the somatic understanding to work with his own symptoms so that he didn't get caught in symptoms. And so I find that kind of example super helpful.
Awesome. Well, look, it was a pleasure meeting you and talking to you, and I'd love to have you back to keep apprised and updated about what you're doing. You're super inspiring, and I just admire your work.
Thanks so much, Guy. It's been great talking with you.
All right, we'll keep in touch.
All right, sounds good.
Bye-bye.
Bye.